So webinar is going live now. It's 3:01. So good afternoon, friends. My name is Dr. Vikram Datta, and on behalf of Nationwide Quality of Care Network Communities of Practice, I welcome you to this January 2021 Community of Practice session. We are proud to host today with us Professor Arti Maria. Professor Maria will be speaking about achieving family-centered care in COVID times. Friends, as all of you are aware, the last 1 year has been the COVID time. It has been one of the most challenging times of most of our lives, and the once in a century pandemic has struck again. It is in these times that most of the neonatal and the perinatal indices have gone down, and the teams are struggling with maintaining the basic quality of care. Well, it is during these times that new concepts like family-centered care, which were still finding roots into the healthcare systems of our country and globally in low and middle income countries, have found it still more challenging to sustain. Professor Arti Maria has been a pioneer globally in starting the concept of family-centered care, not only in India, but also across the WHO Quality of Care Network. We are proud to host Professor Maria today, and Professor Maria will be specifically talking about achieving family-centered care in COVID times. A brief description of the distinguished resume of Professor Maria. Professor Maria is the professor and head of Department of Neonatology at Dr. Ram Manohar Lohia Hospital and Postgraduate Institute of Medical Education and Research, New Delhi. She has innovated and pioneered the concept of family-centered care in neonatal care in India, just as I mentioned. Ma'am is a recipient of ICMR and WHO Fellowships Award and has been an ESQA expert, CHIFAX member, and a nominated ISRHML member. She was nominated by Government of India Ministry of Health as an expert to participate in the 71st World Health Assembly at Geneva in 2018. Madam has been invited as an expert by WHO for developing current standards of newborn care in 2019. She has more than 75 national and international publications and has been a reviewer for various national and international journals. She is a DM and a PhD supervisor and has presented papers at various international and national fora. She is a national trainer for NRP, IMNCI, FBNC, and point of care quality improvement, and has been invited to deliver international webinars on multiple occasions, including those for WHO, USAID, Communities of Practice, Quality of Care Network, ESQA, etc. So I would just stop the brief introduction which I have just rendered for Professor Arti Maria. We are privileged, Dr. Maria, to have you here this afternoon amidst your busy schedule, and we hope that you'll make the most of your interaction with these participants of the community of practice and enthuse them towards introducing and sustaining family-centered care in the challenging COVID times. Ma'am, the screen is all yours.
Thank you so much, Dr. Vikram. And I would say thank you so much for your elaborate. I'm humbled to see the way you've introduced me. Now I shall, without wasting much time, good evening and good afternoon to every one of you. And I really appreciate if you have spared your time to listen to me. So thank you so much. And I think I'll start straight away. Just allow me a moment to share my screen. Yeah. So starting with family participatory care or a family-centered care for newborn, I think it's synonymous with delivering respectful newborn care, particularly in the COVID era. So I shall talk of initially what family-centered care is, and subsequently coming to how far and how much is feasible to implement family-centered care in these COVID times. Am I audible?
Yes, you're audible, ma'am.
Okay. So family-centered care is an approach, it's an attitude, it's a mindset, a concept that aims to develop and nurture families' role in partnership with the healthcare team in care of a patient. Family-centered care, we all realize, and it has been globally acknowledged, it's a humane way of care. It's a gateway to nurturing small and sick newborns. It creates opportunity for lifelong bonding. It's a family's right to a respectful care that we need to protect, support, and promote. It has also been a winning strategy for KMC scale-up, and operational feasibility and acceptability of family-centered care in Indian healthcare setting has been shown to be promising. We have sort of indigenized and developed a culturally sensitive audio-visual training tool to train the mothers and capacitate them so that they can participate in the newborn care of their own sick baby. For that, the first video session, it involves entry protocol. The mother is trained about hand hygiene and how to get into the nursery. This is because it is very pertinent that before we start thinking of a good strategy for complementing care with that of the healthcare worker and involving the parent in the care of their own small sick newborn, and be also developing a nurturing bonding with their own baby, it is of vital importance that we do no harm. And that really means ensuring safe hygiene and universal precaution practices so that there is no added risk of any infection into the nursery. And that is why this protocol is extremely important that the mothers learn. And that is why this entire session is dedicated to this. Second part is about paying attention to the developmentally supportive care. And in this, the mother is taught right about activities of daily living, how the baby can be sponged, can be interacted with, expression of breast milk, assisted feeding, and nesting, and everything about the developmentally supportive. The third session is about kangaroo mother care, and the fourth one is about preparation for discharge and care at home to form a linkage of care at home so that the baby can be brought in back to the facility in case of a danger signs and the early care seeking. So how did we institutionalize family-centered care that has been running at our facility for more than 11 years now? So first of all, at the time of admission of a sick newborn, the family is communicated and counseled, and they're inducted into this program, and identification of primary care provider, whoever can devote time for the continuity of care, is identified. Daily trainings are scheduled with the help of the audiovisual as well as demonstration and practice of the training. Then the mother is supervised under the supervision of the nurse to engage in certain activities that the mother can do. It's also pertinent here to mention that there are very prescribed activities that the mother can do and not everything and anything. It's important equally to say what mother would not do. Certainly the skilled or the nursing activities are absolutely not in the program that the mother should be even asked or thought to do. Then there is a phase of peer-to-peer learning, and it is very interesting and that the mother who's been there for a longer period, how efficiently and how empoweredly she is able to teach a new mother about what to do, how to do. And you can look at the faces of these mothers. They're no longer anxious or, separated. Anxiety is not there. And they are very much happy engaging in the activities of their own baby. Then the mother gets into a stage of independent doing, and that's where the empowerment really comes. And then the mother is discharged along with the family. There is a discharge counseling to establish a continuum of care at home. So essentially, implementation of family-centered care really means right from sensitization, capacity building, engagement in care of the family or parent attendants to establish a link of continuum of care after discharge. Now, what has COVID done? COVID has been something which has hit each and every sphere of our life, each and every person on this earth. The COVID-19 pandemic has emerged as a major public health challenge. Of interest to global newborn health is its effect on breastfeeding practices worldwide. And we all know how vital the breastfeeding is for a survival of all newborns. However, the good news is the overall incidence of COVID-19 in neonates is low. Severity, if at all the disease happens, is low. And only supportive care is required, which is part and parcel of essential newborn. And breastfeeding is considered safe for babies born to mothers with COVID. In that background, breastfeeding among COVID has been said that early interrupted skin-to-skin contact at birth, early initiation of breastfeeding, rooming in, kangaroo mother care, they are the ones key to successful breastfeeding, these early birth practices. And they are known, there is enough evidence to say that they improve neonatal survival, and they are recommended by WHO. However, when it comes to COVID, these have been acknowledged as being difficult to comply with. The guidelines do mention what needs to be done, why it needs to be done. However, how these guidelines may be implemented has been challenging. There wasn't much said about implementation of these guidelines. That was left to each and every person or country to contextualize and adapt. But it has been challenging. The government of India has time to time, concurrent with the times as the pandemic changed its face and the global policies and other things were changing, the disease process was being understood more and more. The government of India issued various guidelines and guide notes, and they do mention that family-centered care also was to be limited and could be practiced in a very, very cautious manner. In a way, there was a setback to the family-centered care for understandable reasons. The mothers, and when there was a community spread, it was not considered safe that this should be an additional hazard to the healthcare workers, and into the NICUs, the status is not known and these mothers are providing care. In fact, admission to SNCUs and NBSUs, however, were to be continued as per existing guidelines. And they also said the critical services for women, children, adolescents should be provided irrespective of the COVID status, and under no circumstance should there be a denial of essential services. But what happened to COVID in the COVID times to family participatory care? Hence, family participatory care was disrupted as healthcare providers could not allow a suspect or confirmed COVID positive mother to enter nurseries for the fear of spread of infection to other babies, as well as the hospital staff. In fact, for extramural nurseries like ours, mothers with unknown maternal COVID status, they were screened initially by symptoms and by PCR, if facilities permitted, before they were allowed to come in. And if they were positive, they were allowed only once they were clinically stable and isolation period was over. So if we wanted to handle these challenges and still reinstate or restore the breastfeeding practices that were badly hit and family-centered care that was hit, what was important? How did we have to manage this. So first step was to appraise, sensitize, and communicate, not only with obstetric colleagues, nurses, and other staff, including sweepers, nursing orderlies, guards, anywhere and everywhere through small group discussions. Also the mothers. The aim was to disseminate clear and consistent communication regarding safety and importance of human milk, breastfeeding, especially during a pandemic, duly following some basic preventive measures. Efforts were also made to dispel any myths or spread of any misinformation. I'll give you an example. When the COVID was at its peak and there was not much known, however, we all knew was the guidelines said the baby and mother were to be roomed in. One fine day, we decided, okay, we need to practice this. And so far until before that, we had been separating any baby with born to mother positive, and that baby was being kept in the NICU in a step down area. And as we decided, we decided we have to be bold and follow these guidelines. We shifted the baby with the mother. And that night, I got a call at around 10, 11 o'clock in the night from the HOD of OBG. And they said, who will take it? Because baby had just been born. They said, okay, who's going to be responsible if something happens to the baby? Because there is nobody except the nurse who stays mostly out in the PPE. So you will be responsible if something happens, a baby falls or baby is hypoglycemic or mother is just delivered, she can't barely take care of herself, etc. And can you believe it? I said it was risky and why I can be taking all the responsibility. I said, okay, let's ship the baby out and we'll consider tomorrow what's to be done. So those were the kind of fears we were all dealing with. And so it was not easy. So this sensitization and capacity building for IPC, infection prevention and control measures, were taken all over across the hospital. The guards, sweepers, and the other staffs were all also trained and counseled, even wearing PPEs, etc. Similarly, counseling also needs to be done with each mother and family at appropriate opportunity of contact, explaining the benefits of and safety of breastfeeding and possible harms of separation or not breastfeeding a baby by a COVID positive mother. Now, the health structures, I'm just getting to that, basically why the FPC got in pandemic got severely challenged. And because there was health structures were overwhelmed, there was a deficit to cope burden. They required major restructuring and expansion. They were labile policies, rapidly changing guidelines, translation into unstable practices with challenges in implementation as a result. An ever issue was of supplies, equipment, logistics, and HR. HR shortage was there because of deployment. There were mobility restrictions, lockdowns, sickness, quarantine, absenteeism, we are all familiar with. The attitude of both receivers and providers of healthcare, there was a dominant state of fear, phobia, and stigma. And there was adverse social impact of lockdown. There were mass migrations and economic crisis. There was paralysis of even existing essential health services. So what to talk of the newborn and baby, which have always taken the last of the priority when it comes to our hospitals and facilities. However, the risk analysis clearly showed us the benefits of breastfeeding outweigh the potential risks of COVID-19. And then what could be talked of cost of not breastfeeding? You know, that it was estimated in the next couple of years, the estimated newborn mortality, 17% of more newborns would die because of cost of not breastfeeding during the COVID times. And that formed the rationale of the recommendations. So now, how to ensure, if all this means respectful maternal and newborn care, then how do we ensure this during COVID times? What are the possible solutions? We have tried to work on it. We did formative research in our department funded by WHO from July to December 2020. It was a mixed method study with in-depth interviews and non-formal interactions with various stakeholders, including from head of OBG, neonatal or pediatric, to residents, to lactation counselors, to nurses, to mothers and families and parents. The objective was to identify enablers and barriers to breastfeeding in a facility setting in a COVID era. This was a mixed method study. So what we realized, actually, it was not realization, it was research showed that the barriers were following: challenges with the guidelines, they were labile, not implementable. There was a knowledge and implementation gap. The doctor-patient interactions were reduced for duration and frequency because of COVID fears. There was lack of opportunity for counseling because of limited staff and their skills. Why? Because breastfeeding support and breastfeeding establishment in the initial part is heavily support dependent and counseling dependent. There was anxiety, fear, stigma with lack of support to the recently delivered mothers. Families even disowned the mothers who were in isolation. They were not willing to go by as birth companions or companions in the postnatal ward. Even they were also dealing with financial crisis, and there was mounting stress. So all this was horrible. And there were other, to top it all, there were compromised maternal and newborn practices. There was preference for home deliveries, fear of institutional deliveries. They thought going to hospital means getting COVID. There was increased cesarean rates. There was care at birth was completely disrupted and compromised. The breastfeeding, there were delayed initiation, lack of lactation support, poor establishment, and all this, top it all, there was exploitation by the infant food industry, which, and you could see left and right, there was formula prescription. They had sort of a boom. So we had to combat all this, and these barriers were difficult to cope with. The newborn care has not been prioritized, as I said. There was inadequate follow-up, unavailability of contraceptive services, commodities, short emergency transport. These are other healthcare challenges that our public health system was facing. Then there was limited COVID testing and disruption of maternal and neonatal services in the routine. However, there were some encouraging enablers, and what they were. For instance, we had to develop and work out systems for us. So there was a zoning which was done in all hospitals, I guess. And this is just to show you how we also did spatial reorganization in our own nursery and maternal wards. I'm sure everybody has worked on it. It was otherwise not possible. So we had to designate areas as COVID positive, COVID negative, definite, and then suspect areas. Now, how did we establish and start working on trying to restore the essential newborn care practices at birth? Let me take you through the journey of right from birth. So we did, and we are now, I can proudly say, we are able to, not only initiate skin to skin, almost nearly, we are able to do this activity in all mothers, whether it is cesarean or vaginal, irrespective of the COVID status of the mother, as you can see. So this is what we aimed at, and we are able to provide this essential newborn care service. Then, so just giving you some examples to say, then the mother is posted, she's transferred in or revealed into the postnatal COVID ward. I'm talking about all COVID positive mothers. So you can see a COVID ward and the baby is roomed in with the mother. These bassinets or these cots are not necessary. If they're there, it's fine. If they're not there, we have even been rooming in babies and mothers. Mothers are explained about the colostrum, importance of it. There is an important element of communication and supportive care. And we have tried to do this so that we achieve the state of rooming in. However, needless to say, the precautions, the infection prevention precautions need to be reaffirmed and sensitized and taught. The bedside sanitizers, bedside dustbin, because mother doesn't have to walk for much. This is babies who are well and the mothers who are well who can directly breastfeed. This is the story for such mothers and babies. After this is about the vaginal delivery born babies. But however, I'll admit that we have not been able to do this for cesarean mothers. Soon after birth, the rooming in is not happening and we have not been able to find a solution how to room in these babies who are born to COVID positive moms and delivered through cesarean, because mother is alone. We cannot rely on the nursing staff who's actually deployed from all over the hospital departments. And in this ward of COVID ward, there are all kind of specialty. We have insisted, I have been able to get maternal patients all in one ward, and so that there is no mixing of male, female, and other non-maternal patients. However, the risk that a cesarean mother, she's already having pain and she often may be catheterized. So how can she manage a baby? That has been an issue. The parents, the family attendants have been offered, but I have rarely come across a person who was willing to come and be there 24 hours, first 24 hours in the cesarean case. And even if they did, there are logistics which are prohibitive, like how many PPEs can you give? How does he go out? He has to food, he has to go to the toilet, he will have to change many times, lots of PPEs, etc. So there were issues of those sort which we have not been able to resolve. So you can see the mothers are being sensitized through the videos for family-centered care and learning expression and breastfeeding activities, expression, direct breastfeeding, positioning, latching, etc. And we do provide support. Rounds are being taken, morning, evening they're taken. We are providing them phone numbers. And this is how we have been able to restore practices. And we do provide lactation support even in the COVID isolation ward. So when mothers are COVID positive, and then the second state, I'm saying first was baby healthy, mother healthy, and we showed how rooming in and skin to skin and rooming in and continued expression and establishment can happen. This is the second scenario when mothers are COVID positive and separated from the baby. This is challenging. These mothers must be counseled and supported to express breast milk starting as soon after birth as possible. And I'm telling you that skin to skin has been possible. So that's the opportunity of contact when you counsel them and tell them to start expressing your milk. We do actually physically help them and support them, preferably within as soon as possible after birth, and preferably not later than first 6 hours after delivery. And this is key to establishment and sustenance of breastfeeding. Mothers are explained that colostrum is absolutely vital for her baby. And this is the first thing. I'm not saying this baby is separated from mother. The mother is separated from her baby who's sick or small and in the nursery, or a cesarean baby. It is a second step I'll talk about, that how this milk can be transported to the baby. This is just as much to say that she must express the baby, express the milk, whether or not we are able to reach it or not, whether the baby is in a condition to take it or not, but expression is must for mothers who are separated from their babies. Then she's motivated for continued expression. Just initial expression is not important. Subsequently, continued expression for 8 or more in 24 hours. So she must continually express. She must be taught about expression. It can be done through manual or through a breast pump. Breast pumps we have not been able to find useful. Now let's come to, I talked about maintenance of supply, expression of 8 or more in 24 is necessary. Now, breast pumps, there were issues. We tried to work on that, but there were issues about washing them, disinfection them, who would do all this, and who would teach the mothers how they will be maintained, and there could be a risk of infection and otherwise. So that was not able to be implemented in our COVID wards. Then we had to look for zipper bags and personnel to transport the collected expressed milk. Who would do it, how it will happen, this we had to work out a lot. And we have been able to institutionalize that also for babies who are separated and them getting the express breast milk. So needless to say, again and again, we had to teach mothers about, when we have put up posters, we are developing IEC material for practicing respiratory hygiene, wearing mask, washing hands. So if you want to remember, www. mask, wear mask, wash hands, and wipe the surfaces around. So WWW. So mothers, you can see they are being taught. And this is about now how this milk will reach the baby. So you see the mother has been provided with clean container. You can see this, a steel container which is pre-labeled with her name. And then she expresses milk. And then this is being cleaned from outside and put into a zipper bag. The zipper bag is being now handed over. The milk is being kept into the zipper bag. And then it is being kept by the attendant outside the nursery. And it's being handed over to the attendant, and then it is kept inside the nursery or in the buffer zone. And then this, the nurse or somebody picks it up from here, and they discard this zipper pouch. They are into PPE because this is a COVID babies ward. The mothers who are positive, their babies are kept in a transit area, which is the COVID isolation ward in the nursery, where babies are kept babies are kept whose mother are positive. And this is done, isolation for these babies is done till the mothers turn negative, or earlier if the babies are negative themselves. And then this container is cleaned out of the pouch and cleaned with the disinfectant wipes. And then gloves are discarded. And then this baby is fed to the EBM is fed to the baby, or it is stored in the refrigerator if there is a delay or it cannot be fed immediately. So you see, it requires a lot of design, which is perfected and passionate, and persistence and perseverance is required on part of a lot of motivation is required on the part of the healthcare worker to design that this happens. It doesn't happen on its own. So there's a lot of effort that goes, but I must say it is needful that needs to be done. So after use, the EBM container is washed and with soap water, and then rinsed with boiling water and kept for air drying, as you can see. And then again, this empty container is packed again into the zipper pouch and then handed over to the family member who takes it to the mother. And that the cycle is complete. Now, you also must appreciate that these mothers are going through a lot of stress because of separation, their own sickness, and the fact that COVID positive. There is psychological stigma. Families have disowned them, separated from their sick babies, and issue of small sibs or small babies being left unattended at home, and other many more stresses. So our hospital has developed some psychological support material, and we need to do that a lot. So counseling for mothers and healthcare workers is going on, and telephonic counselings also we developed for our, even not only for the mothers, but also for our healthcare workers, faculty residents, because a lot of them got COVID and they were put into isolation, which was very depressing. Now I'm telling you that this mother, you can see she is being counseled, and then there was this issue of this, I must acknowledge, we learned this from GTB Hospital. Dr. Sushil was kind enough to allow us to mimic or, let's say copy this. And we got an idea from here. And we have used this use of a tablet in the mother as well as in the NICU, the isolation ward of the nursery, of the mother, as well as in the nursery. So what we have done is that the mother is having a tablet, or the nurse shows her the tablet, where she can be shown that her baby who is being cared in the nursery can be seen. So she's able to see her baby's state. Fear of unknown is much more. So if she's able to see, actually, she feels very satisfied. It helps in her lactation also. And she can see that her milk that was collected and so much of effort has gone in is actually being fed to the baby. You can see this particular mother watching her own baby being fed. So it was very satisfying. You can see that again. And the fathers also can see what is happening through their phone. So we had tried to extend this facility and use of this technology for our benefit. And you also saw that the doctors shared their number with the mother because there were not too many mothers, so it was feasible. Now, once the mother is ready to come to NICU, there's still the screening of this sort is done and her PCR has been done. Then we get into the routine practice of family-centered care as much as possible. So mothers are back into the routine of being taught hand washing, entry protocols, and then, but things are much, much more stringent. The challenge was there were resources and logistics were less. However, we have tried to do our best in the way we could. And you can see how babies are safely transported, family-centered, again, at its own original self in a limited manner. So general precautions for mothers and family participation, that standard precautions, hand hygiene, mother or caregiver must wear mask, respiratory hygiene, cough etiquettes were taught, minimum visitors, that too after screening, social distancing, mask use, cough, sneeze etiquettes, hand hygiene, one healthy family member following contact, and droplet precautions may be allowed to stay with the mother, however, that they rarely agreed to. There was an intense counseling and communication needed, and families should be informed and understand the isolation, monitoring, diagnostic treatment plans were given, and they were given periodic updates, and there was use of video and phone calls. And you can see now mothers, after they are declared as COVID negative or known to be COVID negative, they are participating in the family-centered care and things have resumed. However, as I said, access to breast milk and maintaining supply still remains a challenge. This is ROP screening continuing during COVID times. And now just to tell you, I have mentioned that family-centered care, whether during or not COVID times or no COVID times, essentially means three primary things. It needs creating infrastructure, which is family and mother conducive. It should have mother-friendly facilities. It needs attitudes. And let me tell you, the biggest challenge is the attitudes of the healthcare workers, which needs to turn around a lot. Be accepting and, accepting mother as a partner in care. Once you accept them, that means you'll go an extra mile to make it happen. What is respectful for the newborn and mother to be provided. And then lastly, the practices. What we do, how we do, actually determines whether it is family-centered or not. So if this was the principal premise of family-centered care, and these are the pillars of making it happen, you can understand what each of these domains mean during COVID times. So creating infrastructure and facilities, I've shown you amply well how much we need to go extra mile, including logistics, etc. And our attitudes need to be those of not only overcoming our fears and phobias and stigmas, we need to go and empathize with these mothers, communicate, counsel them, provide physical and emotional and mental support, and then make practices happen. And that is the key to implementing family-centered care and practices most important of infection prevention control, that means IPC. And this is what will make FCC happen in our restoring FCC in a limited manner and a safe manner. So then is the preparation for discharge. And as you can see, things are much different than otherwise. There is thermal screening, there are floor markings, social distancing, there are OPD measures and antenatal OPDs everywhere. This is, and the follow-up, follow-up was decreased and we tried to do a immediate follow-up through telephones. However, follow-up has resumed to normalize, but with different precautions and different looks. So to conclude, firstly, safety first. To provide a respectful maternal newborn care during these challenging times has been really, really challenging. Family participatory care can be practiced, but in a limited manner. Infrastructural readiness, attitudinal acceptance, logistics support, communication, education, psychological support to both receivers and providers of care is of paramount importance. However, key newborn care practices must continue for babies born to both COVID and non-COVID positive mothers, like early skin-to-skin contact, delayed cord clamping, exclusive breastfeeding, or expressed breast milk or donor human milk where EBM is not available. Mother's own milk is not available. Rooming in unless mother and infant are separated because of any of them being sick or not in a position, for example, in cesarean, but should be brought together at the earliest once they are stable. Express breast milk to neonates who are separated from COVID positive mother. These are the key practices which are a right of a newborn, and we must do it as a duty and responsibility to make it happen. The key message I would like to leave with, before I go on to key message, one more observation that caught my attention during this period. It was not just that the COVID positive mothers and the breastfeeding suffered in them. There was a bad outfall was that the mothers who were not COVID positive, even breastfeeding among those mothers and babies also was challenged, and it fell down. Why? Because there was fear. Mothers wanted to stay in the hospital for shortest period. They were requesting early discharge. Once the delivery was done, they wanted to go home because they thought staying in the hospital was risky. And when they want to go home, obviously the hospitalization was short. Time for opportunity for early support and initiation of breastfeeding was minimized. Doctors and healthcare workers wanted minimal contact with mothers, although they may be negative, because there were instances when mothers initially negative turned positive later. And the whole lot of healthcare workers, about 14 of them have gone on to quarantine for variable exposures to these mothers who later turned positive. So there was error and there was fears on both ends, providers as well as receivers end. And therefore mothers, when they are leaving hospital early, that means the breastfeeding support and establishment doesn't occur. Then they resume to formula. They go on to formula, and then formula means the whole breastfeeding cycle is interrupted, gone for a ball. So therefore, breastfeeding even among COVID negative mothers suffered. So it is a challenge. We all must take a pledge. We need to restore these breastfeeding practices and make sure once the COVID is gone, or even if it was to stay, unfortunately, we must fight it and make our babies get the best essential newborn care that they deserve. My key message is to make respectful maternal newborn care a reality for the baby. A strong leadership is required on the top. Interdepartmental coordinations are required. Mother and newborn must be considered an inseparable diet, COVID or no COVID, whether it is COVID, pandemic, emergency, anything. Strong maternal newborn diet support through peripartum, birth, and neonatal period is required. We can explore our own ways and means, but how to make it happen? For example, with help of birth companions, lactation counselors, etc. And we must continue to leverage upon the family-centered care that still seems promising. We need to innovate indigenous ways and need to contextualize and adapt the guidelines that should be feasible, effective, and sustainable in our own setups. I cannot give you one prescription that will work for everybody. We have to these are ideas that I have proposed, but how you want to do it in your own setup, what is feasible, please work out. The community empowerment will ensure continuity of care at home, because these babies are at a risk of getting sick again and possibly dying. So we need to ensure the community empowerment will protect them and continue to protect them through continuity of care post-discharge at home. Of course, cross-learnings are great opportunities. And my final key message is, give the care that you wish to receive. Together, we can. Thank you very much. And I want to introduce this on the last note. This is FCC, Family Centered Care at its best. I want to show this mother, Salma. she was the one. In fact, we've written a case study on this. It will be published on Healthy Newborn Network. And this is a mother who had chronic renal disease, and she was in a chronic dialysis. And this was an ELBW who was, I think, 600-700 grammer. And this baby mother was admitted for 3 months in the dialysis nephrology ward. And the father and grandmother, the mother-in-law of this Salma, they were the ones, they were, through the thick and thin of her times, mother, you can see grandmother continued to provide, and this baby was discharged on exclusive breast milk. So this was an example of, and the father came to nursery. They didn't have a place to sleep. They were in the corridors, on the, benches, sleeping, taking turns, and they were visiting the nursery, continuously supplying EBM. And this is an example of family-centered care at its best, even during the COVID times. So I just want to end it here, and I wish we all can do our little best to make things happen to the best. This is something we celebrated in Breastfeeding Week, and this was through the pandemic, and we had a theme of safe breastfeeding for a healthier planet this time. So we had a lot of competition amongst nurses, residents, all of them, and we had skit and role plays. So just to say that, things have to go on. Thank you very much once again. If I've exceeded time, please excuse me.